on how did we reach up to the stage where Rajesh could do surgeries for such a difficult cases. So there has to be a evolution of any surgery, and that holds true for endothelial keratoplasty also. For this presentation, I'd like to acknowledge the help of Dr. Manpreet Kaur. She's working with me as an AP. I think the initial concept of endothelial keratoplasty is basically like people like me who came through early stages of full thickness graft and anterior laminar keratoplasty. We had no concept of going through a posterior route in these cases. We always thought about having an exact fit of a tissue which we're going to replace, which should have a perfect anterior and posterior smooth surface. In that regard, I think the initial surgery would have been the historically posterior lamellar keratoplasty through anterior approach. Then now we have a posterior approach, which we call a modern day EK surgeries, and future would be a no keratoplasty. I hope this comes out in these cases. Let's see how this entire endothelial keratoplasty evolved in last almost 60 years or so. The first description of posterior lamellar keratoplasty for endothelial disease was described by Titiyal et al. In 1956, published in AGO at that time. And he had done a large incision, which is almost 180-degree in the host cornea, then did a stromal dissection through this 180-degree incision and removed the entire button, which involves a posterior stroma as well as endothelium, then implanted the donor tissue through this large incision and subsequently sutured it. So this was later modified by Baraka in 1960s. We all know he was pioneer in microkeratome surgeries. So he did a hinge flap surgery in these cases and posterior trephination of stromal endothelial bed and put the lenticule sutured in the stromal area in these cases. So we're looking into these. There have been many other people worked in this regard in late 90s and early 2000, and prominently they were Galveston, Busin, Arfa, Eller, Silk, and Dimitri Ajar. They describe these techniques in a different manner. If you look into John Dart and Galveston, they describe this as endothelial lamellar keratoplasty, and subsequently Busin described this as endokeratoplasty. They all worked through the anterior approach, and Dimitri Ajar also worked with the keratome flap-assisted posterior keratoplasty. He referred in a JCRS publication. So these are various people worked in this regard to improve the endothelial disease and trying to maintain the anterior cap in these cases. But you see, there was a definite need of shift from anterior to posterior lamellar keratoplasty because these anterior approach did not really give a good outcome in terms of they require a larger corneal incision, a larger corneal flap, and a lot of suture-related complication to attach this donor lenticule into the existing host stroma. And they also had a significant angular curvature glaucoma because of synechia formation. There was a large endothelial damage that subsequently led into failure of these grafts. And ultimately, what we would have thought about getting a good posterior apposition in a stromal bed, they had a very poor apposition of a graft in these cases. Therefore, there was a definite need of innovation, evolution of a newer modern day endothelial keratoplasty. That was basically as posterior lamellar keratoplasty described of Mellis in 1998, subsequently by Mark Terry as a DLEC. Then we had in 2004, we had a D6 surgeries. Subsequently, Price made more popular procedure. Then we had automated surgery in 2006, and now we have DMEC described by Mellis in 2008 and PTEC in 2014. I was getting through the article published by Mellis. What would have been a thought to getting into the posterior part? There were five important things which made him to do a posterior root surgeries. He had seen DMD cases in a cataract patient getting attached to the air injection. Then he did an experimental study to see if the endothelial lenticule can be attached. In these cases, that would be anti-gravity surgery without suture. And he realized there's a negative inhibition pressure, as we described the endothelial function in the beginning of this session, would also work out in the opposition of lenticule in these cases. And the stromal surface of donor as well as host will have a much better stickiness of a transplant tissue in these cases. And he was the first person to realize the air bubble can effectively work in attaching these lenticule in these anti-gravity way in these cases. And he came with the new technique of PLK in 1998, where he described the air bubble tamponade of a graft in these cases without suture. So this was one of the first surgery of without suture endothelial keratoplasty. And the Malise technique, the donor preparation was almost similar what we do nowadays for a routine manual dissection with these cases as such. You see this technique described, donor full globe was taken because artificial chamber was not used. And he did a 60% dissection into the stoma, and then after the dissection, he put a plastic sheet there and then cut the cornuscular rim on a Teflon block. He punched 7.5 to 8 millimeter, then subsequently removed the plastic sheet with the remaining anterior stomal thing. And this was a donor preparation. A host preparation also, he had to do a larger incision, which was almost 7 to 7.5 millimeter. Then there's a scleral tunnel at 60% depth, 80 to 60% depth in these cases. Then remove the posterior lamella, which had a stoma and disease endothelium by a punch. Subsequently implanted the lenticule with air bubble placement in these cases, and the host was sutured. There was a concept which later Mark Terry in 2000 described his technique as a D-leg in these cases. That is a deep anterior lamellar, posterior lamellar keratoplasty in these cases. So he had described many instrumentation. Very interestingly, these are still being used for a dissection. The curved dissector, Devers and Terry dissector used for lamellar dissector. He had a specific punch, Terry's punch made for a posterior punching of these cases. Later, he described this long Cindy scissor, right and left hand, to cut this posterior dissected piece of stoma and endothelium. And this was the Olsey insertion spatula, where the surface will be coated with the viscoelastic and graft is to be endothelial side on to insert inside. Later, he did describe the smaller incision surgery where the donor lenticule could be folded and inserted inside. And that was the technique to describe the smaller incision, because larger incision induced much more difficulty in managing astigmatism of these patients. So this was a technique which did have a rapid visual recovery as compared to the full thickness surgery in these cases. They did have a graft clarity also. But the vision was not perfect in these cases, and it was a very difficult procedure as such, not easy to replicate by other surgeons. I remember we also procured these instruments and could not replicate the procedure in our place also. This led to exploration of alternative procedures for endothelial keratoplasty. And Mellis in 2004 described a simplified method where he totally eliminated the lamellar dissection of recipient stroma, which was a major difficult part in these cases, and only described the descemetorhexis in these cases, where descemet endothelial complex was taken away and placed the donor lenticule as described by him. And initially, he described this under the injected air bubble in antechamber to have a better visibility of descemet during scoring. Or sometimes he did put a reflectile glide inside, which also would give you a better initiation and better completion of a descemetorhexis. And sometimes you could use the forceps on these cases and did a 9 millimeter mark anteriorly and subsequently scored from behind. But this surgery was ultimately made more popular by Francis Price group, and they described various techniques in these cases. And he compared microkeratome dissected lenticule later, but it was Groboy et al. Who described this earlier. This technique was described in 2006. So this was the study by Francis Price where he compared microkeratome versus the manual dissection. And he concluded that microkeratome dissected tissues are better in terms of attachment, and the visual quality is also better, and recovery was faster in these cases. But in DSEC and automated DSEC also, there was a challenge of graft dislocation. We all face this. Many more patients require multiple sessions after a surgery, pupillary block, glaucoma, and graft failure. And we all looked into how to modify these procedures to decrease complication in these cases in this regard. In this way, to have a better attachment, in between 2008, Mark Terry had advocated a peripheral scraping of the stroma just beyond the 6 millimeter optical zone. And this he thought would increase the adherence of graft in these cases and decrease the chances of post-op dislocation. Then he also described a Cindy sweeper he could use anteriorly after injecting air pressure. Anterior sweeper will decrease the chances of dislocation post-op period. Meisler et al. Described the anterior chamber air fluid infusion or exchange in these cases. Roboy had the idea of a total air fill for at least 1 hour of surgery, then subsequently dewerfing in a slit lamp. Price et al. Talked about fenestrations, stab incision interstoma, which was quite popular in the beginning. And he described if you have combination of venting incision and the air pressure and massage, the chances of post-op dislocation from a 50% would decrease to 6%, which was successful procedure as such. We also had IOCT visibility of these cases. We also tried to compare how effectively we can assess the lenticular apposition in a DSEC surgery. And we realized if you do a combined procedure of anterior massage and continuous anterior chamber pressure with air, also decreases the time. In a primary surgery of DSEC, we could see within a 1 to 3 minutes of manipulation, bimanual manipulation, the graft was well attached. So this understanding will decrease the pressurized eye for a longer period in these cases. So this is what we could see in these cases. The majority of time, post-op pupillary block was a major concern. People would remove the air bubble to a smaller size, do a peripheral iodectomy like we do for DMEC surgeries. Some people use a mydriatic cycloplegic things. A similar technique we also described to decrease the problems. But change happened in terms of getting a good dissection of donor lenticule in DSEC surgeries. Microkeratome, femtosecond were used to get a thin lenticule in these cases. Apart from talking about ultra-thin DSEC, which is a very popular method, now people talk about nano-thin DSEC lenticule, which is less than 50 microns. Maybe this will have a better visual outcome as compared to DMEC or be equal to DMEC also. There are various nomograms to do. I think Parveen did talk about assessment of a femtosecond laser issue. We also published our results where we compared the endothelial damage with electron microscopy studies, and we did a atomic force microscopy to see. And it is correct that microkeratome are much better than a femtosecond laser of today's generation to prepare lenticule in these cases. Insertion wise, we had spatula to begin with, then came forceps to decrease the size further. Then we have glides, and you have injectors, inserters, and these all were made changes to decrease the damage which can happen during manipulation or injection of these lenticules. And Mark Terry did describe larger the incision, better is the retention of endothelium. Tighter holding of a tissue also will have more damage in these cases. IOCT have a better visibility, gives a better analysis of what is happening inside in these cases. Then let me talk about how DMEC came into practice, because DSEC would not give enough quality of vision which we talk about as compared to the physiological surgery with DMEC in these cases. And it was the peeling techniques I described initially with the direct peel method. We still do a direct peel method, or you have a big bubble method by creating the big bubble like you do for cases where DALK, and subsequently punch it from endothelial side. So you have a manual peeling technique of Melange and Lee, then scuba technique, which Price had described earlier. But we have all gone into this, and we know that direct peeling techniques, manual peeling techniques are better in these cases. The endothelial cell loss is quite less, 4 to 7% with the manual peeling technique as such. So peeling techniques has been now, I think we can standardize them in a better manner and get a better endothelial cell count in these cases. Pneumatic dissection, now it is basically limited to cases with PDEC, which has been made popular by various people attached to Agarwal group. Then in between, we had a hybrid technique because unfolding or demarc tissue was difficult. So you did have a little bit of stromal tissue in the periphery so that you could do a better unfolding in these cases. PDEC, as talked about Praveen, we know that younger donors can be taken up in these cases. And this, I think, is still in a modifying phase where you use a glass pipette or IOL injectors to insert the roll inside and opening the roll. Various techniques have been described to make it simpler and better, where you have different types of folds inside. Accordingly, you have to design how you're going to improve these. So it is better to have orientation seen in your through the microscope or through other resources. See the correct orientation, which is like this for your cases, and unfold them better. So there are stampings, or you can have various other signs which can be give you a better orientation. Like this one, you can see the cannula giving a blue reflection. That means you have a right orientation of graft. OCT will also give you a better understanding what type of role you have and what technique you have to do it in these cases. As various videos are shown by Praveen and Dr. Fogla, now we can do a EK in all types of surgeries where endothelial dysfunction has occurred, and that's because we have evolved from the early stage to a modern surgery in these cases. I think this will be covered by the coming speakers. The future will be a no keratoplasty or DVEC, which may be a good indication for early cases of Fuchs as such. Rho kinase inhibitors or endothelial cell transplants, culture endothelial cell transplant may be a future of surgery in EK. To summarize, I think we did have anterior approach because that time we didn't have a concept of posterior approach. We never thought lenticule can be attached without the suturing in these cases. Then came the idea of putting a thin lenticule from posterior side with a small incision, sutureless, and people still do this, one of the commonest surgeries. Now a DMEC, which is just replacement of endothelial descemet complex with healthy donors, would remain for a longer period. Any surgery which can be replicated by various surgeons would be a suitable surgery for patient, for surgeon as such. I would thank you for listening for this talk. If you have a correct orientation of a surgical aspects or disease, you definitely have right perspective of what has happened in the future and what has happened in the past and what is going to be future of endothelial keratoplasty. Thank you for your kind listening.